For our Zoom session. And today we are treating postpartum hemorrhage, maternal and neonatal resuscitation. So without wasting much time, I will hand over to Prof. Kalia to kickstarts for today. Yeah, welcome once again, Prof. Please, you can take the floor.
Yes, thank you so much, Abigail, and thank you everybody for bearing with me and waiting for me. Unfortunately, I got stuck at work, but here I am. So today, yes, as Abigail said, it's our final session on Zoom because that means we are getting closer to meeting in person, and that is in almost 11 days' time. Okay, so very soon. So by mid-June, we'll be meeting each other in Ghana. So today we're going to wrap up with a very important topic, okay, postpartum hemorrhage, which unfortunately, is one of the main killers of mothers up to this day. And even, the cause also, of morbidity as well as mortality, of course. And then we'll touch upon maternal and neonatal resuscitation. Now, just to remind you, when we meet in person, we'll be having hands-on sessions using mannequins, using dummies. And among the things that we will be covering, we'll be doing assisted vaginal delivery on the mannequin, we'll be doing breech delivery, we'll be doing shoulder dystocia, and we'll also be doing maternal neonatal resuscitation. Now, I'm very sure that you're very well versed both with maternal and neonatal resuscitation, especially neonatal resuscitation. But it always is good, even for me, to update myself. Because as you will see, especially the neonatal resuscitation guidelines have just been updated only last year in 2025. Of course, there aren't major updates, but it's always, the idea is also always to make it safer and make it give a better result, of course, with resuscitation. Okay, so let's start off. Postpartum hemorrhage. So, okay, just wait for this to respond. Yes, postpartum hemorrhage. As we said, this is a very important topic, and what we plan to do today is we're going to list important causes of postpartum hemorrhage. I have another mnemonic for you, which is the 4 T's, which are the 4 causes of postpartum hemorrhage. The 4 T's being tone, tissue, trauma, and thrombin, but we'll go into a lot of detail about them. In fact, today's session, the majority is going to be based on postpartum hemorrhage. But of course, we'll have time also to update ourselves on the neonatal and maternal resuscitation guidelines. And we'll also describe methods for preventing PPH. As the saying goes, prevention is better than cure. So rather than be faced with an emergency of major PPH, preventing it is better, of course. Sometimes, it is difficult, actually not sometimes, but often it is difficult to recognize PPH. The thing is because, of course, very often it is the visual, you base yourself on the visual, on the amount of clots, but the PPH might not all be obvious. You might have external hemorrhage, right, which you're seeing and you're literally the blood is on the floor and it's everywhere, and you're actually, as you, for example, suturing the perineum, blood is falling on you, so that is quite obvious. But it could also be internal hemorrhage, leading to a hematoma, for example, which might not be that obvious. So we're going to go also through ways on how to recognize PPH. And of course, we're going to also describe the management of PPH, at least the initial management till the underlying root cause is treated. Okay, so it is common, even in our, practice, even with mothers delivering in a hospital, it is up to 5% of vaginal deliveries. But of course, that figure that percentage can go up even higher in higher risk population. Okay, and as I said, probably this figure is still an underrepresentation because a number of PPHs go unrecognized. So what is the definition? The definition really and truly for a normal vaginal delivery with PPH is losing more than 500 mils of blood, which when you think about it, it's very easy to lose 500 mils of. I mean, if you're talking of cesarean section, the PPH in that case is usually defined as 1000 mils, like 1 liter of blood. And when you think about 500 mils, I mean, it can easily happen. Of course, it's a potentially serious complication for the mother, and as we said, it's one of the commonest causes of maternal morbidity and mortality worldwide, even in mainland Europe. It still remains the major cause of maternal death. So, what are associated factors? What are associated risk factors? I think the most obvious, of course, is multiple gestation or any other causes of overdistension of the uterus, so having twins or triplets. I mean, if there is, let's say, a fibroid, so the mother is pregnant, plus she has a big fibroid, especially if this fibroid is intramural or submucosal, that is within the, it's impinging on the cavity. So those are causes of overdistension. Of course, antenatally, you could have also preeclampsia, and as we mentioned when we're having the session on preeclampsia, it can lead to HELP syndrome with problems with coagulation, and it can also lead to disseminated intravascular coagulation. Nulliparity, so being the first pregnancy, is also a risk factor. As is previous cesarean section, all right, because of the risk of rupture of the uterus, and also, of course, a previous postpartum hemorrhage. So someone who in their previous pregnancy had postpartum hemorrhage, you have to be more on the lookout for a potential recurrence of this postpartum hemorrhage, be it whichever is the cause. So, I mean, it could be that she has an underlying problem with her clotting, which may be, led to the first postpartum hemorrhage, but the underlying thrombophilia wasn't diagnosed. And of course, now she's pregnant again and she's more at risk. Okay, or she has a problem in the uterus. Let's say there's a big fibroid, which led to the postpartum hemorrhage in the first pregnancy, and now second pregnancy again, and this fibroid is still there. Maybe it has grown, and therefore it can also lead to postpartum hemorrhage. There could be, apart from antenatal risk factors, that could also be, of course, problems happening intrapartum, so which are particular to
Yes, please, you're muted.
Sorry about that. Sorry about that. Thank you, Abigail. I don't know why that happened. So I'm not sure at which point I'm muted, but had I finished the antepartum risk factors? I think so, right? I had finished the antenatal risk factors. So this, I think you had heard me, and I think it's from the intrapartum risk factors, right? Yes. So from the intrapartum risk factors. So I'll continue from. Okay.
Yes, Paul.
Thank you. Thank you, Abigail. And thank you for pointing that out. Okay, so intrapartum risk factors for PPH. So these include a prolonged third stage, that is when it comes to delivering the placenta, that's prolonged. If it's more than 30 minutes, you have to think of potential retained placenta. okay? And of course, that's going to affect the contraction of the uterus, and the more time it takes for the uterus to contract, the more the bleeding, which is happening from the placental side. If there has been arrest of descent of the head, and therefore leading to prolonged labor and a more tired uterus, if there is an episiotomy or a laceration, particularly if the laceration is also affecting the cervix, that's going to lead to bleeding. If there is assisted delivery, with forceps and vacuum, there is an increased risk of PPH, and you might ask me why. Mostly it's not only because of the fact that, for example, if you do a forceps or vacuum, you have an episiotomy, and therefore there is increased risk of bleeding, but also the reason why you had to do the assisted vaginal display. So if this was a prolonged second stage, for example, so again, after delivering the baby, the uterus is tired because she has been in the second stage, or maybe there was a prolonged first and second stage, and therefore there is an increased risk of atony. And also if labor needed to be augmented. Okay, because if labor needed to be augmented, it's probably because there was a prolonged first stage, and therefore an increased risk of getting PPH. Now, you might not have any of these risk factors and still get a PPH. So really and truly, for every delivery, even the most straightforward one, you have to be on the lookout for PPH, okay? Because a lot of PPHs happen without an obvious underlying antenatal or intrapartum risk factor. Okay, so how can we prevent it, or at least prevent the effects of postpartum hemorrhage? So first of all, it's important that antenatally you treat any anemia. Now, we know that even the most healthy mother, her hemoglobin levels will go down purely because of the physiological increase in hemodilution, right? But still, she has a low hemoglobin, right? So it's important to treat any underlying anemia, because of course, if the mother starts her labor with a low hemoglobin, if she loses, of course, she has less reserve. Of course, if possible, avoid routine episiotomy. In fact, I remember a time when we used to do routine episiotomy, but then we stopped that because, by doing a routine episiotomy, unless it's obvious that she's going to tear, doing routine episiotomy, you're increasing the risk of bleeding. Active management of the third stage, okay, so active management of the third stage, we do that for every delivery. And in our country, in Malta, all deliveries happen in hospital. And also after delivery, in the mother. So you check that the uterus is contracting, so you continue monitoring the mother after delivery. So when we talk of management of the third stage, so you could do expectant management, where you wait for the separation to happen and you leave the cord uncut and leave the placenta to deliver spontaneously. And then after the placenta is delivered, you give oxytocin or, put the baby to the breast or both. To be honest, we always go in our practice for active management. So upon the delivery of the baby, and there has been shoulder delivery, and of course, the baby, oxytocin is given, the cord is clamped and cut early, and there is controlled cord traction. And that probably has been done in order to try to decrease PPH. And I think, the literature shows that with active management, you do decrease the incidence of PPH. Of course, if unfortunately PPH is happening, okay, so you recognize that the mother has bled substantially, so more than 500 mils. And especially, I mean, she is literally becoming unconscious in front of you. And remember, pregnant mothers have a lot of reserve. So when their blood pressure starts going down and their pulse starts becoming steady, that means that they have lost a lot of blood. Okay, so probably they have lost about a liter of blood. So you have to be quick in recognizing PPH and to start off the measures. So again, like basically every emergency that we've dealt with, you always call for help. Even if you're the most senior person on the delivery suite at that moment with the mother, you can't do it all on your own. You need more hands. You need more hands on deck. So you call for help and you start taking care of the airway, breathing, and circulation. This we're going to go into a lot of detail when we do the maternal resuscitation. So, of course, if the mother in front of you, she's collapsing, right, and it's because she's bleeding, you first need to make sure that her airway is correct so she can breathe, and also take care of the circulation. So you put in two large bore IVs, IV cannulas, and that's why you need help to be in the room, because these cannulas need to be inserted ASAP, especially if the mother doesn't have a venflon yet, doesn't have a cannula yet. You put on the oxygen, and as you're putting in the cannulas, you also take blood for cross-match. I mean, and you ideally have 4 to 6 units available. You check your hemoglobin, even though, as you know, the hemoglobin will not drop immediately, but at least you've got a baseline hemoglobin to start with. You also check the coagulation factor, so you do your repeat-INR, take your U's and D's, right, and put in a catheter. And you have to have a low threshold for considering transfusion. That's why, I mean, you send the bloods off and ideally alert your blood bank that you have a PPH, so they are on alert. So as as the cannulas are being inserted, as your assistants are putting on the oxygen, you, as the person who has just delivered this lady and have recognized the PPH, while this is happening, you need to be massaging the uterus. Okay, so you can't let go of the uterus and just go and stick the two cannulas or put the oxygen. So that's why you call for help. The others are taking care of the oxygen and of the IV bore cannulas, the cannulas. And while you are staying next to the right next to the mother and apply uterine passage in order to draw up a contraction. You need to inspect for lacerations to try to see where the bleeding is coming from, and be quick to think about giving oxytocics, basically because hypotonia, low tone of the uterus, is the most common cause of PPH. So even if there is an obvious wound, an obvious laceration, and the bleeding seems to be coming from there, you need to make sure that the uterus is well contracted. And be quick also to alert theater, because you might need to intervene surgically if the bleeding continues. So what are the four main causes of PPH? So these are the 40s. So as I just said, 70% of causes of PPH is due to atony, reduced tone. And that happens because of overdistension of the uterus or fatigue of the uterus. There has been prolonged labor. Sometimes you can't find the reason why there is reduced tone. Okay? Trauma, which include mostly lacerations, leads to 20% of postpartum hemorrhage. Retained tissue is 10%. This usually retains placenta or parts thereof. And clotting disorders like thrombin is about 1%. However, PPH, which gets out of hand, can quickly end up in DIC, in disseminated intravascular coagulation. I think one of my worst experiences of PPH was I was still a junior doctor on delivery suite, And a colleague, she's a pharmacist, but we were at school together. So a colleague my age came in, first baby, and her waters had broken, and she was contracting. And of course, I mean, she stayed on delivery suite and she delivered a healthy baby boy, and everyone was happy. And being her first baby, she had, I mean, what looked like a relatively small tear, a second degree tear. And, I thought, okay, I'll do the suturing for you. And, we started chatting as I was doing the suturing, but I was noticing that there was quite a lot of bleeding, which was coming from the uterus. The midwife had left the room because she left us chatting together. And, this bleeding was just increasing. And I put my hand on the uterus. It was big and boggy, and as I massaged it, clots started pouring out. And within literally what looked like seconds, it was probably minutes, but it's just that, it happened so quickly. The blood coming from the area of the episiotomy actually suddenly, instead of being, like red blood, like as which coagulates, suddenly started becoming like, just more clear and not clotting. And it was falling on the floor and it was clotting. Like the previous blood was clotting, this wasn't clotting. And immediately I said, but how can it be? It's already in the IC. But, she had lost so much blood and she had so much clots inside the uterus that, yes, she was spiraling into the IC. And we rushed her to theater. I mean, the husband was left there, traumatized, of course, because, there was barely any time to explain to him what was happening. In theater, she needed to receive, about 6 packs of blood. And then she also needed fresh frozen plasma. And it was actually at the point of giving her the fresh frozen plasma where the bleeding started subsiding because the DIC started getting under control. But it was, traumatic because it was unexplained. She had no real, risk factors. And like you went to school together and everything. But luckily, she made it. She made it. Following the delivery, she took her time to think about her second baby, but eventually she had a second baby too, and it wasn't with PPH. Everything was fine. Yes, and we still meet sometimes, with the children. So yes, that was a good ending. But of course, unfortunately, not all women who have PPH have that good ending. So that's tone, trauma, tissue, and thrombin. Now we're going to go into a bit more detail into each of these causes. So if we look at tone, so as I said, tone is because of uterine atony, and that tends to happen because of oval distension. So for example, macrosomic baby, or twins or triplets, or muscle fatigue if she's been in prolonged labor, inflammation due to infection, of course, that makes the uterus more boggy and soft. Also, if there is problems with not allowing the uterus to contract. So, for example, if there is a large fibroid. Okay. Trauma, that's usually laceration to the cervix, vagina, or perineum. It could also happen at cesarean section if there is extension of the scar. Of course, uterine rupture, and also grand multiplicity. Tissue, so tissue that has to do with the placenta, so parts of the placenta being retained. Also, placental abruption, which would happen antenatally, but as you know, when in placental abruption, the blood kind of seeps through the uterus, and then the contractions are very difficult to happen properly. So the uterus, even after remove the placenta, remains it makes it difficult for it to contract properly. And of course, if there is retained placenta, and even more so, if there is the placenta stuck, to the uterus, in an abnormal way. And remember, persons who have had a previous cesarean section, if you get implantation of the placenta over the cesarean section scar, there is an increased risk of placenta creta, increta, and percreta. We'll talk about that very soon. Of course, it could be placenta previa, okay, which especially if the placenta previa is on top of a previous cesarean section scar, that is actually the worst recipe because, there's the risk of course, antenatal bleeding, but even part of the previa being an accreta. Okay, we'll talk about this in very soon just to describe what they represent. And unfortunately, because of the increasing cesarean sections, we are seeing more placenta, accreta, increta, and percreta. Okay, so that would be abnormal implantation where the placenta is stuck too much to the uterus, and therefore when it comes to delivery, it doesn't deliver on its own. Okay, and then problems related to clotting, so what we refer to here as thrombin. You could have so people who are born already with a problem with their clotting. It could be acquired coagulopathy, so maybe receiving, or because of low fibrinogen as a result of disseminated neurovascular coagulation, which in itself can result from other pregnancy complications, okay? Be it PPH itself, be it preeclampsia, HELP syndrome, sepsis, okay? All right, so again, emphasis on tone, uterine anatomy. So it is the most common cause of PPH. And, if you should always, someone with PPH, start by assuming that it is coming from lack of uterine anatomy and just go straight away to apply the bimanual uterine massage. And if need be, with compression. Because irrespective of where the bleeding is coming from a tear, but you can't afford more blood loss from the uterus itself. Okay, so be quick to consider using oxytocic agents, which might include oxytocin, ergometrin, dimethyl ergonovin, prostaglandins, misoprostol, and tranexamic acid. And we're going to describe these in detail as well. And if it persists, you should also consider balloon tamponade, okay, depending on what you have available. All right, but you always start by manual uterine compression and massage. Okay, so while recognizing the PPH and while starting the oxygen and the two IV bore cannula and the IV fluids, your hand should not leave the uterus, the abdomen. So you're massaging the uterus, and if it keeps filling up and feeling boggy and there doesn't start restituting, then be quick to go for the bimanual uterine compression, where effectively with the abdominal hand, you're pushing downwards, right? You're like wrapping up the uterus and pushing downwards. And with the vaginal hand, you are compressing the uterus. The idea is that you don't let the uterus fill up with blood and clots, because of course, the more it fills up, the more it's difficult for it to contract. Oxytocin, now you might have already given that during delivery, perhaps, or or upon the delivery of the anterior shoulder, if you're doing active management. But if she still continues bleeding, you either give 10 units IM or start off an IV infusion. And the IV infusion would be 10 to 40 units. Very often you go for the 40 units in 1 liter, and you're giving it over 4 hours, basically. Oxytocin is pretty safe, okay? And yes, it might give you a transient hypotension, but you're giving also IV, and the hypotension is happening anyway because of the PPH. So I mean, in this case, I mean, while you're doing the uterine massage and by manual compression, the oxytocin is being infused and helps to maintain that uterus contracted. If there isn't underlying preeclampsia, okay, you can give the ergometrin, especially if she's already on the oxytocin infusion, for example, or you've already given the oxytocin, or it's not enough, okay? You go for your IM ergometrin injection. I mean, that's what we give. You can also give the methyl ergonovin, but we give the ergometrin. And the only thing is that, I mean, if she has preeclampsia or eclampsia, it's contraindicated. If you're not sure whether the mother has preeclampsia or not, okay, and the mother, of course, is bleeding and she's hypotensive, you are justified in giving the ergometrin if the oxytocin is not enough, because, I mean, even if she were hypertensive, okay, with PPH, she's hypotensive, okay? But if you know that she has hypertension, then, I mean, she had herself hypertension, you might use alternatives to ergometry. And what are these alternatives? Again, it depends on what is available in your armamentarium. For example, what the guidelines say and what we also have available, I mean, mind you, this wasn't available since ever. Like I've been on labor ward now since 1999, so almost, I mean, 26 years. And I do remember, you know, I would say for the first 10 years, so up till, yeah, I mean, 2008, 2009, I remember when the prostaglandin started being introduced on our unit. So before that, I mean, it was only oxytocics, and yes, that's what we had in the ergometry. But I mean, now we have been using carboprost. It's also known as hemabate. It's basically carboprost and hemabate. They are a type of prostaglandin F2 alpha, which help with uterine contraction. And they tend to be using different receptors from the oxytocin. Okay, so you instigate this if the oxytocin infusion or IM oxytocin hasn't worked. And how is it given? It's given either IM or intramyometrial. To be honest, it's licensed for intramuscular use. The intramyometrial use is really off license, but I mean, you can use it, especially, for example, if your PPH is happening during a cesarean section. I mean, if she's bleeding and the uterus is not contracting during cesarean section, you can give it intramyometrial. Normally, I mean, after vaginal delivery, IM is quite quick to act as well. You can actually give up to 8 doses at 15-minute intervals. So that means you can give it every 15 minutes for a maximum of 2 hours. But in reality, once you're at the point of having to give the hemabate, you don't wait for 2 hours before you do something else. So really and truly, once you've given your first dose of carboprost, you start transferring the patient to theater. And of course, as time passes, you give another dose, but if you are about to give the third dose and the bleeding is still torrential, you have to do something even more drastic. Carboprost, why is it not given first line? Because carboprost has more side effects than oxytocin. I mean, it can cause nausea, diarrhea, flushing, headaches. There have been cases of people being hypersensitive to it. And again, I mean, the mother suffers from hypertension or asthma or cardiopulmonary disease. You can't use it, or you have to use it with caution. As I said, with hypertension, I mean, if she's bleeding excessively, even though she's hypertensive, I mean, probably at that moment she would be hypotensive. Okay, so what else could be used? I mean, misoprostol has been used for a very long time, even in the treatment of PPH. It is an effective treatment. It's cheaper, of course, than, for example, hemabate. You don't need to put it in the fridge. It has a long shelf life. And I mean, it can be given either PO or PR. Of course, in this case, you don't give it vaginally because the mother is bleeding torrentially. She should just, bleed it out. So it's either PO or PR. And each tablet is usually 200 micrograms. So it's either 3 or 4 tablets. Many people give 4 tablets. And especially if you have a home delivery or if there is no access to Haemorrhage, it is used, can be used. Now, so it is an option and it saves lives. Tranexamic acid, I mean, again, it's probably the more recent addition to the armamentarium out of all the medications that we've mentioned. Again, it needs to be given as an IV in case of PPH, and it's a fixed dose of 1 gram IV, okay, which has to be administered over 10 minutes, and approximately every 30 minutes, okay? And it is also very effective. I mean, of course, you need to have a cannula and you need to have this refrigerated. Tranexamic acid, basically, there was a trial, I remember when that trial was published, and because tranexamic acid had already, and it still is, used very much for other causes of hemorrhage, like, in A&D, whenever there's trauma, there's massive hemorrhage, tranexamic acid is used. Let's say someone is involved in an accident and there is, let's say, one of the limbs gets amputated. It's used in pregnancy, not in pregnancy, I mean, in PPH, took some time, probably because of the fear of thrombosis. But, I mean, at this stage, when you have PPH, I mean, realistically, I mean, what's going to kill the patient is the PPH, not, possible thrombosis at this stage. Of course, it needs to be used with caution. Of course, tranexamic acid is also used very widely in women with menorrhagia. Okay, with menorrhagia, to stop the bleeding, tranexamic acid is used as well. All right, and then, of course, you've got the tamponade, the balloon tamponade. There are various uterine balloon tamponades which can be used. For example, in our unit, we have the Bakri balloon, that probably was the one which was specifically designed for the uterus. You can also use the Sengstaken tube, which was originally designed to treat stomach bleeding from the stomach, but the same principle, you could also use it for the uterus. So that's the Sengstaken Blakemore tube, right, which is the one shown here. Okay, and the Bakri is the one over here. There are other variations of it, but more or less it's the same principle. So the idea is that this catheter is placed in the uterus, okay? In the case if there is atony, and the uterus is not contracting, and you put in that catheter, you inflate it and press down, all right? And then once the bleeding starts, and in the meantime, you're giving your oxytocics, your medicine, in order to control the bleeding. And then eventually, once the uterus starts contracting and the bleeding starts subsiding, you start deflating that catheter, okay? And then it is tamponading. It's also useful if there are, of course, other reasons for PPH. Okay, so there's the Bakri. Okay, so where, of course, the balloon needs to be inserted completely into the uterus, and then you pull down in order to tamponade the uterus. Okay, so we've spent some time on tone, which is fair enough because, as we said, tone, you've got 70% causes PPH to hypotonia. Of causes or and/or cervical lacerations could be tears or could be because of episiotomy, which has extended. Less common causes, but very dramatic, are uterine inversion and uterine rupture. And of course, you could have hematomas, for example, extending down to the vulva, but that would be because of an internal bleed, which then gravitates into the vulva. The problem with such a hematoma that you might not be able to see the bleeder, okay? And you might not be able to estimate the amount of bleeding. But if there is a large hematoma, as I show you some pictures, that can easily amount to 500 mils or more. All right, cervical laceration. So if it is a small cervical laceration, that usually doesn't lead to PPH. But if there is a large cervical laceration, okay, that needs to be repaired, because it's not easy to repair it. You need the patient to be fully relaxed, and it can bleed a lot. So it needs to be done in theater by someone who's experienced. Uterine inversion. So uterine inversion is rare, uterine inversion during a vaginal delivery. To be honest with you, I myself had seen a uterine inversion, not during a vaginal delivery, but actually during a cesarean section. So it was a lady who was having her second cesarean section, so she had a previous section that was being pulled out. It was, let's say, a little bit stuck. In fact, it turned out to be the placenta creta. And as the surgeon was pulling it out, the uterus literally inverted. And because it was during cesarean section, but in those few seconds, literally, as the uterus was inverted, the anesthetist, who was, by the head of the patient, and there was this, so we couldn't really see what was happening. The anesthetist suddenly said, "Oh, what's happening?" The heart rate stopped. So for a few seconds, there was actually a vasovagal effect where there was bradycardia, practically, severe bradycardia. Okay, in that case, it was kind of easy because the patient was open during the cesarean section, and the uterus was quickly reverted back to its original position, and then waited some more time and then scooped out the placenta. However, during a normal delivery, it might not be that obvious till, you're pulling on the placenta, and then this suddenly you see that there is part of the uterus which is inverting, and that really will lead to shock. So the shock, the mother will undergo cardiovascular shock, and although she's losing blood, it would be, the shock is disproportionate to the blood loss, so she collapses. Okay, so upon recognizing that there is this uterine inversion, you need to replace the uterus immediately, even if the placenta is still stuck to it, because of this vasovagal reflex that she goes unconscious, and the heart undergoes severe bradycardia. So this is how an inverted uterus would be. So the first degree, you might not realize that there is an inverted uterus because it's not obvious. It's not obvious from the outside. The second degree and definitely third degree are very obvious. Of course, if you are in the third degree, the mother definitely have a vasovagal reflex and probably would already be showing signs of shock. Okay, she probably would be collapsed at that point. So, and this is a uterine inversion because the placenta was stuck to the uterus. So as the placenta was being pulled out, just behind it here, you can see the uterus, which turns gray. That is the amazing thing which happens with the uterine inversion. I mean, I had experienced it during a cesarean section. The uterus from, red, pinkish red, it just turns gray because the blood supply would, upon uterine inversion, the blood supply stops. Okay, it immediately turns gray. So what's the treatment? You have to restitute it. Okay, so of course, if it is third degree, you have to grab it and push it in and keep it inside. Okay, so it's like when you're doing your bimanual compression, but in this case, it is just the putting the fist in and keeping the uterus in. And then you would need to, following that, proceed to the bimanual compression, because as you are pulling out your hand, you need to make sure that the uterus contracts rather than it kind of falls out again. Okay, so that was uterine inversion. Uterine rupture. So uterine rupture, actually these, again, I would say they are a bit on the increase, these uterine ruptures, and probably that's because uterine rupture is associated with prior uterine surgery, with the uterine surgery common as being cesarean section. And we are seeing an increase in cesarean section rates. And of course, when the mother comes pregnant again with her second baby, especially if she's going for a trial of normal delivery and for a VBAC, there is an increased risk. And of course, the more cesarean sections there have been, so if she has only one cesarean section, the risk is so much. And it's relatively low, so she can go for a normal delivery, a trial of normal delivery after one cesarean. But the risk increases if she's had two cesarean, and definitely it's very high if she's had three cesarean sections. In fact, in our hospital, when a mother comes with her third cesarean section, we counsel her and consent her, of course. I mean, she agrees to have her tubes ligated during the third cesarean section. Because if she gets pregnant again, then she gets pregnant again after a three cesarean section, there is an increased risk, of course, of uterine rupture. So when uterine rupture happens, how do you suggest it? How do you suspect it? Of course, I mean, it would happen during labor, during the second stage. And if it happens, there is a sudden change in the fetal heart racing. There would be bradycardia. In the meantime, the contractions would somehow stop, okay? And it's very dramatic. Okay, it's usually accompanied with bleeding. And there is a lot of pain. The mother, she's in shock, and there is tachycardia. And the signs of shock would be out of proportion to the visible blood loss. You have to be quick to recognize this and immediately go to theater and, to save both mother and baby. So in that case, you have to go to theater and do a crush cesarean section. Another cause of trauma leading to PPH is valvular hematoma. So this would be typical valvular hematoma, and you can see that there's blood even extending on the sides. And the problem with this is that, of course, I mean, there's a lot of bleeding, but it's trapped. The source of bleeding might still be there, you don't know. And it's difficult to estimate the amount of blood lost. But if you see a valvular hematoma, you have to assume PPH. And you have to try to find where the source is. Okay? Especially, I mean, if the mother's parameters are getting worse. Okay, so we've mentioned tone, which is 70% of causes of PPH. We've mentioned trauma, which is 20% of causes of PPH. Now we come to tissue. So tissue, you've got approximately 10% of causes of PPH. And the most common reason is the retained placenta. So if you've got a placenta which is not delivered within 30 minutes, then it is a retained placenta. And it can happen in up to 3% of deliveries. As I said, it's getting a little bit more common because of, increased risk of invasive placenta from previous cesarean sections. And remember that once you deliver the placenta, even if it comes out during the third stage, relatively easy, it's always important to check that the placenta is complete, right? Because retained placental fragments can also, of course, lead to PPH. Now, of course, you might get caught out if the placenta looks complete, but in reality, there is an extra lobe, right? An extra lobe which has been retained, and of course, there's no way of you knowing until she gets PPH, and then you do the ultrasound and you see this retained lobe. That's not common, but it can happen. Okay? And the invasive placenta, we're going to go through that. That's the placenta accreta, percreta, or increta. All right, so when it comes to delivering the placenta, the recommended way is what we call the blunt maneuver, where you wait for, so the baby has been delivered, and then you wait for the cord lengthening, all right? So that shows that the placenta is becoming detached, and then with the abdominal hand on the uterus, on the fundus, that's elevated by external upward pressure, and you apply gentle traction on the cord. The idea is that like that, you don't cause inversion, and you're more likely to get a complete placenta out. Okay, so that's what we call the blunt maneuver. If there is a retained placenta, so you're doing this, but the placenta is not coming, you need to proceed to a manual placenta removal. So you normally wait at least 30 minutes, If you declare, okay, then the placenta is not delivering on its own, you cease the uterine massage. You will actually give a tocolytic or put the patient under anesthesia, and then you do the manual removal, which is not a very nice procedure, but you actually insert your hand, you try to identify the cleavage plane. You, of course, have to be careful that it's not a placenta accreta, so you can't find the cleavage plane. And you have to be mindful, the accreta. You try to cup the redons in your palm and try to remove it intact rather than piecemeal. And of course, after removing the placenta, you explore the uterine cavity. And then you give the oxytocin. So you don't give the oxytocin before, you have to give the oxytocin after, because if you give the oxytocin before, then it's very difficult for you to do the manual removal of the placenta. Now, in some units, it's not in ours, but it's being described in other units, they actually suspect that there is retained placenta. Before proceeding to a manual removal, they actually inject oxytocin intraumbilically. And the protocol is that they give 2 mils, basically to 20 international units of oxytocin and 20 mils normal saline. To be honest, it's not a practice that we do, but it's been described. And in the literature, where it's done, it's described as reducing the rate of manual removal by substantially. Okay. So in our practice, we go for manual replacement straight away in theater. But I guess, if the theater is not available or you're doing a home delivery, this is something that could be done. All right, so the normal placenta versus the placenta accreta spectrum. So we talk of the placenta accreta spectrum. Accreta means stuck. So you've got the placenta accreta only, where the placenta is attaching a bit too deeply in the uterine wall. So normally you know that the placenta basically attaches to the uterine lining. So in fact, the maternal deciduum, which is the maternal uterine lining, contributes to the formation of the placenta. That's the maternal side of the placenta, the decidua, and then you've got the fetal side of the placenta. However, there is a layer, which is the decidua basalis, basically, which would be the layer that when we get our period, we shed the lining, but there's always a basal layer which remains in the uterus. The period, it regenerates again, proliferates again, and then becomes secretory for the next either pregnancy or period. But in the case of placenta creta, you get the placenta, the chorionic villi, which they adhere too closely within the basalis layer. So not in the muscle, but very close to it. If the villi actually invade into the muscle, that becomes the placenta increta. And the placenta percreta, which is like the worst because it's the placenta behaving like a tumor, it actually not only invades into the uterine muscle, but actually goes out to the uterine muscle. And I mean, if this happens to be anteriorly, actually, it even can, get stuck to the bladder. Of course, out of these three, placenta percreta is the worst. And that, of course, will lead not only to retained placenta, but even to BPH. If you're dealing with a case of placenta percreta, you try to remove as much of the placenta as possible, but then usually the mother will need treatment. We usually give methotrexate, which is a type of chemotherapy in reality, okay, to help shrink the retained placenta. Right, and this is showing the placenta creta spectrum a bit better. So that is the normal placenta, where there would be the layer of the endometrium basalis, and then the myometrium, which is the uterine muscle, and the coverings of the uterus, which is the serosa. The case of a creta, so basically it goes all through the endometrium. So the endometrium basalis is no longer there. The increta, you've got the villi invading into the you've got the villi invading into the myometrium, and if it is percreta, not only is it invading into the myometrium, but right onto the serosa and possibly even outside. Okay, so that is the most serious. As I said, I mean, these used to be very, very rare occasions, but because of the increase in cesarean section, I mean, for a number of reasons, cesarean section, I mean, in our practice, sometimes we get women themselves asking to have a cesarean section even if there is no indication, just because they're afraid that if they push, they might get prolapse, etc. But of course, if you come to have your second delivery or third delivery and get the implantation at the site of the cesarean section, there is an increased risk of the accreta, uncreta, and even percreta. I personally have never encountered a case of placenta percreta, but I've seen cases of percreta, of accretas. Okay, so coagulopathy. Coagulopathy, so that is the last T, which is the thrombin, coagulopathy. So that could happen because of pre-existing conditions that the mother has. So you might already know about them from pre-pregnancy, but it could also happen that although the mother had them from pre-pregnancy, pre-existing, but they show up during pregnancy. Maybe she's never been to the doctor before, and the first time she is encountering the medical profession or healthcare is during pregnancy. And that could be the immune thrombocytopenia, ITPs, or von Willebrand's. And the von Willebrand's is a congenital condition. But she could also get coagulopathy, which is acquired because of obstetric-related causes. Right? So, for example, if she has preeclampsia or hypertensive disorders, the HERP syndrome, if she had placental abruption, so during abruption, actually a lot of fibrinogen is used up, and therefore that leaves her with the coagulopathy. Unfortunately, if there's a stillbirth, fetal demise, and if she has sepsis, those all consume a lot of the fibrinogen and make the mother more prone to coagulopathy. Of course, she might be taking some treatment like aspirin, which, let's say, she's taking it because of preeclampsia, for example, and that also makes the blood thinner and makes her more at increased risk of bleeding. Now, we do give aspirin to our patients, especially if they've been having recurrent miscarriages or if they have hypertension, preeclampsia. But, I mean, we ask them to stop the medication, but there is enough time, a month's time before delivery. But of course, if she's on aspirin and she enters premature labor, I mean, so let's say she starts contracting at 34 weeks and she's still on aspirin and she delivers, I mean, because of the aspirin, she's at increased risk of bleeding. Okay. All right. So, in that case, what test do? You need to take a CBC, complete blood count with platelet count. You need to do an APT-INR, and ideally also check your fibrinogen levels, because if they are starting to get low, you are risking going into DIC, and you might need to give fresh frozen plasma, of course, in order to stop the guidelines. So in the case of thrombolytic issues, I did treat the underlying disorder, and you need to give transfusion, but you might also need to give FFPs. So in the case that I mentioned before about my school friend who got postpartum hemorrhage, upon receiving the 6th unit of red blood cells of blood, she actually needed the FFPs, because even when you're giving a transfusion, just because of the way that the transfused blood is stored, it wouldn't have fibrinogen in it. So as a standard, I mean, with every six units of blood that we give, the advice is to give FFP after the 6th unit, I mean, or upon giving the 6th unit, in order to replace the fibrinogen which would have been lost. Okay, you might need to give platelets. Okay, platelets, and you try to aim for the hematocrit, of course, to be high enough, so like that, that I mean, you are keeping the clotting situation under control. Okay? So in summary, for PPH, it can be predictable, so you can prepare from before, but very often it's unpredictable. So you have to be prepared. And it's unpredictable either because of factors which happen intrapartum, or even if the delivery seems to have been very straightforward, you can still end up with uterine atony for no apparent reason at all. Uterine atony is the main cause of postpartum hemorrhage, and the other causes are trauma, tissue-related problems, and thrombin-related issues. And doing the active management of the third stage does help to reduce PPH. Okay, so we've managed to cover postpartum hemorrhage. I must admit, it is one of my favorite topics, though, I mean, to teach, not to be present when it happens, because when it happens, PPH, I mean, okay, in most cases, you have a good outcome, but unfortunately, it can spiral out of control very quickly. And as we said, it's one of the main causes of maternal morbidity and mortality, unfortunately. But, if treated systematically, and again, having everyone on board so everyone knows what to do in cases of emergency, it definitely can help us save lives. So please, any questions?
Thank you very much, Prof. Please, if you have any questions, kindly put it up in the chat box, or you might as well unmute and just ask the question. For some few minutes before we continue. So
Yes. No, we're well on time.
yeah.
We started a bit late. Yes, even though we started a bit late, but we're well on time.
Yeah, yeah.
And this is one, I mean, it is one of those topics which you really need to know. And these cases, they tend to happen, when you have the most junior person on call or in the
Mm-hmm.
middle of the night, when
Mm-hmm.
you expect it.
Very true.
May I ask a question myself, if you don't mind? So, in your unit, I mean, do you use the Bakri balloon, for example, or anything similar? Is it something that, you normally resort to?
The PPH, Prof.
Yes, for PPH, I mean, the balloon tamponade, is it
Uh-huh.
something that you resort to relatively early, or is it something that you use as a last resort?
Um, we interchange it. So it's either we are using the misoprostol,
Okay,
the
yes,
tranexamic acid,
yes.
or the balloon tamponade, the
Okay.
condoms. Yes, please. So we interchange depending on the severity of the
Of the
bleeding.
bleeding.
Yes, please.
So usually, so it is oxytocin, then misoprostol,
Misoprostol, and then yes, please. In that
and
order.
okay,
Yeah.
good. And the carboprost, I don't think you use.
No, Prof.
Yes. I mean, I don't blame you. I mean, as I told you, I remember when it was introduced, it was about 2010. And I mean, it has its side effects, plus it's more expensive. You have to keep it in the fridge. You have to be in hospital to give it. And it's really a temporary measure. It is a temporary measure. So I agree with you. I think misoprostol is probably a very good first line. In our case, the misoprostol is kept in the DDA just
Mm-hmm.
because, of course, it can also be used to, I mean, for abortion, so it's kept in the DDA because abortion is illegal in Malta. And probably that's, I think, one of the reasons why we don't resort to it first line, just because you have to get the permission to use it. So if you have a PPH, we go for the oxytocin, ergometrin, and then the hemabate. But the hemabate, you need to be starting to move to theater to do the hemabate or carboprost.
Oh, okay. Okay.
To be honest, the balloon tamponade, it's usually inserted as a very, very last resort, before, let's say, having to do an emergency hysterectomy, So but I think it comes from the fact that I guess it's what people are comfortable using and what's available.
Right. I think there's a question for you in the comment section.
Yes. Yes, thank you for mentioning this. Yes, yes, yes. Dr. Philip, the B-Lynch or hysterectomy. Yes. In fact, I was going to include it, and then for some reason I didn't include it. So thank you for reminding me of this. Yes, so the B-Lynch or hysterectomy, of course, if so you're at the point that you've given the medicines. And as I said, the order that we give is usually the oxytocin, then the ergometrin, then the carboprost. And you've given the first carboprost, right? And nothing is happening. I mean, she's still bleeding. You're going to wheel her. Then, I mean, even if she's delivered normally and boggy and not responding, then you're going to go for the B-Lynch or hysterectomy. Now, again, it depends a little bit on the experience. So, admittedly, for hysterectomy because of lack of experience in doing the B-Lynch. So few people have actually ever done a B-Lynch, and so they go for hysterectomy. I think I've assisted about 2 or 3 emergency hysterectomies. I mean, they're not nice at all. I mean, even when it comes to, of course, I mean, they're dangerous because, I mean, the uterus is so large and there's so much bleeding and it's literally like working underwater. The problem with B-Lynch, although it's very good and it works, is getting the experience to do it. But thank you for mentioning, Philip, because I wanted to insert a slide and then I don't know what happened and it didn't get inserted. So thank you for that. The B-Lynch is basically you are preserving the uterus, okay? So unlike hysterectomy where you have to remove the uterus, therefore you're compromising the fertility of that lady and it's a more major surgery. With the B-Lynch, it's literally you're doing a big suture around the uterus and then around 2 big sutures around the uterus on either side, like 2 braces, and then you it's like creating a purse string in order to keep the uterus contracted. And they're left there, okay? And now there is quite a lot of experience, I mean, in the published literature, that not only does it work because it's kind of physically keeping the uterus contracted and you're preserving the uterus, but even there's a possibility of pregnancy later on. Someone who had B-Lynch. I think the initial B-Lynch was using nylon, but I think now they changed from nylon to other material, either catgut, but I think then catgut eventually got retracted from the market because of the mad cow disease, and I think now they're using Vicryl or a combination thereof, which ultimately takes some time to dissolve, but it does dissolve, unlike the nylon, which can for much longer. And the idea is so that the mother remains fertile and can have pregnancy after. I myself have never done a B-Lynch and have never seen one done. I would really love to see one done. I've just learned about it in courses or from the book. I've never seen one done. Have any of you ever seen a B-Lynch? I mean, I've seen hysterectomies, cesarean, but I've never seen a B-Lynch. Have any of you ever seen a B-Lynch?
Um, I I don't know if he has or Dr. From I don't know if he has. Yeah.
No, neither.
Okay.
I mean, on paper, it looks really good. I mean, Christopher Lynch, who was the inventor of this procedure, I mean, of course, in his hands, I mean, he has a very large case series and he keeps publishing about it. And as I said, I mean, now there is a big case series of women who got pregnant after having had a B-Lynch in a previous pregnancy. I mean, and when you think about it, it's easy, I guess, but I've never seen it done. And I'm not sure if there are courses. I mean, I guess you can get courses done on dummies, but it's very difficult. It's very different from doing it in real life on a big postpartum boggy uterus. That, Philip, thank you. They said it was one of the things I needed to include, and somehow it just slipped my mind. So thank you.
Right, Prof. Thank you so much. Um, so I wanted to ask, do you think there are any barriers in reducing PPH related death in low and middle income countries? Because it looks like um it is one of the leading causes of maternal mortality worldwide.
It is.
Yes.
It is.
And then there are a lot of studies going on and on.
Yeah.
But then in your studies, do you think there are any barriers that is going to help reduce PPH related death in low and middle income countries? Thank
I
you.
think I think the even in the both in low and middle income, but even in the affluent countries, you always find those pockets of people who are vulnerable and at low socioeconomic risks. And ultimately, it's the access to antenatal care. I believe that the answer to PPH is having good antenatal care. You need to, have at least have had at least one ultrasound by 20 weeks in order to establish the number of babies, like whether it's singleton or twins, etc., the location of the placenta, okay, and correcting the maternal anemia. Which, as I said, part of it is physiological, but if you already have an underlying disease, an underlying deficiency, you need to correct it. And by having good antenatal care, the risk of PPH, I think, does reduce substantially, at least from the preventable causes. And then it is the training of the birth attendant. So I think, in Malta, speaking for my country, luckily, the last 20 years, we didn't have one maternal death from PPH. And in the last 12 years, the two deaths, we get about 4,000 deliveries a year. So we're a small country and we
Have
get
you said
about
last
4,000
20
deliveries a
years?
year. The last 20 years, we never
Oh,
had the
wow.
PPH. Yes, we never had the PPH. But Abigail, everyone delivers in hospital. Everyone delivers in
Mm.
hospital. So it's 4,000 deliveries a year. Everyone delivers in hospital. And although there is a private hospital, they barely do any elective work. Sorry, they barely do any, they only do elective work like cesarean sections, and they have to be low risk. So, and they don't do much, so all those 4,000 deliveries happen at hospital. But prior to that, so we go back, for example, I was born, I'm 50, so I was born 50 years ago. And it was around that time that people started to move away from home deliveries to delivering in hospital. But for example, my mom's time, so my mom is 77, my mom's time delivered at home. To go to hospital, it had to be something really, really, really big, but otherwise everyone delivered at home. And for example, my grandmom, when she was delivering my mom, she had severe PPH. Luckily, the midwife who was attending to her knew what to do, and she probably did the uterine massage, and she was saved. But many women at that point, who delivered at home and didn't have proper, probably antenatal care, but even not having a birth assistant who recognized that there could be PPH. Therefore, unfortunately, these women, bleed to death, But then the move towards delivering in hospital. So yes, we might be blamed with more medicalization of the delivery, but that has led to no deaths from PPH. The last 20 years, it might be more, but since 20 years, we have a register of all the obstetrics, and there has never been a PPH, a death, PPH-rated death. There has been PPH, but not a PPH-rated death. But the last 12 years, so actually we didn't even have a death, maternal death for the past 12 years. But the last year, so 2025, we did have two deaths, but those two deaths were not related to PPH. They were both of them unlucky because they had previous medical conditions which were not recognized before, and then they ended up with complications after delivery. So they were postpartum deaths. One of them, actually, she had a thyroid complication, and then within 2 days of delivery, she had a big goiter, which, basically, unfortunately, she died because of suffocation, literally. And the other lady, she actually had severe puerperal sepsis. Severe puerperal sepsis. So she, yes, she died of severe puerperal sepsis, but somehow went unrecognized. So she had a normal delivery, she went home, and then by the time she came to hospital again, she was very, very, very sick and was already spiraling down. And we never got down to what exactly caused that puerperal sepsis. I mean, we never got down. But I mean, she was a lady who unfortunately had recently moved to Malta. So even antenatally, we didn't know much about her. Then she came to hospital to deliver, left hospital, and then, yes. So, but I think what has led to the decline in deaths from PPH was better antenatal care to recognize the preventable causes and delivering at hospital, or at least having trained who are quick to recognize the PPH.
Mm-hmm. Right.
That prevents that. It doesn't prevent PPH, so we do get people with PPH, but yeah.
The
So
response are quicker.
yes,
I'm sure
yes.
about Okay. Do you have a different medication in treating anemia during the antenatal level? Okay, what do you use in treating anemia?
Okay, so we do a complete blood count upon booking. So they get a CBC at 12 weeks. By 12 weeks, everyone would have got their CBC. And if we find that their hemoglobin is low, we start iron supplements. Okay,
Prof,
so
what is the low? Sorry for cutting you. What is your low?
for us would be 10.
10.
10, yes. So on average, women would have between 11 and 12. If they are at 10 or below, they start iron.
Okay.
Now, an interesting fact in Malta, being in the Mediterranean, we do get quite a number of women who have thalassemia trait. So thalassemia trait is, it gives anemia, okay, but it wouldn't be iron deficiency. So if we have someone who looks healthy, no shortness of blood index, and they have hemoglobin less than 10, before, I mean, we start the iron, okay, but we also get them checked for thalassemia. And if they do have thalassemia trait, the husband also gets checked for thalassemia. The reason being because if they are both thalassemia traits, then the baby would need to be screened for thalassemia major, right? So thalassemia is, the name thalasso is salt, and in the Mediterranean region. I don't know if you have that in Ghana, but here in the Mediterranean region, it's very common. So these women would still receive iron. So these would be iron supplements. So typically iron supplements, which are oral iron. I think it would be iron sulfate, I think. But these would be over-the-counter iron supplements. If it is very low, if the ferritin is very low, so let's say 8 and she's not thalassaemic, they receive IV iron.
Okay.
Okay? They receive. Now, if this CBC gets repeated again around 28
Mm-hmm.
weeks, and if the iron is still low, okay, they again either have to continue their supplements or get an IV iron. If they are closer to delivery, so let's say they're 36 weeks and already their hemoglobin, I mean, it's at 8 for whatever reason, we also counsel about receiving a transfusion. Because, I mean, if the hemoglobin is very low, I mean, if it is close to 10, again, they continue with the iron or IV iron. But if it is, let's say, 8, we counsel for having a transfusion. I mean, of course, some people refuse, which is, I mean, it's their right if they want to refuse, but then we're very careful, and even postpartum, then we encourage, again, either IV infusion of iron or a transfusion.
All right, sure. Thank you, Prof.
I guess, I mean, you see quite a lot of PPHs, I guess. Mm,
Um, Not on the high. And as for the anemia, we see a lot of them. So that was why I was
Okay.
asking
Okay.
what your low or what your low CBC counts for HBS. Yeah.
In
So if it's a 10, it means we need to increase their iron supplements
Yes,
for them.
we do. But do you
Okay.
get maybe sickle cell anemia? I guess you get some sickle cell anemia.
Yes, 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 Prof. We do.
Yes.
Yes.
Mhm. And then, I mean, the other causes of anemia that you see, would it be because of maybe
The
um,
thalassemia.
thalassemia?
Not no, I have not witnessed that. I think maybe Dr. Philip will be able to help us if
Okay.
they've had no, but then I've not seen anyone with that issue before.
I think you wouldn't see a lot of thalassemia in that.
Yeah.
It's
Yeah.
usually more around the Mediterranean,
Okay.
and interestingly enough, even in South Asia. So there are in areas in India they also get thalassemia. Maybe maybe because of the history and there were colonizers who colonized there and they carried kind of the thalassemia gene with them. But here,
Right.
in we see,
Okay.
luckily most of them just have the trait. All right,
Mm.
so they get okay, they mild anemia, but they live a completely normal life. Those who have thalassemia major, there is the treatment as well, so they can live and they can have a normal life. But yeah, in fact,
Okay.
what we also do actually, um, part of the pre-marriage counseling, right?
Mm-hmm.
They actually have a blood test done to check, that, for example, the wife and the future wife and her fiance don't have the thalassemia trait.
Okay.
And we do, but children, I mean, there is the treatment also for the thalassemia major.
Okay. All right, sure. Thank you so much, Prof. I think there are no more questions, so we can proceed to the next part.
Okay, so let's go to the next one. And we were here. All right. And we're going to be talking about maternal resuscitation. Now, this maternal resuscitation will be one of the things that we will revise when we are meeting in person, okay? Even though I'm sure you're all very well versed with this. So what I'll be doing is I'll be highlighting some particularities that you do for resuscitation, but when you're dealing with the pregnant mother, okay? So reason for resuscitation is, of course, if the mother has a cardiac arrest. Okay, so and then she needs CPR. So it can happen. I mean, it's not common, but it can happen. And the thing is that when it happens, of course, in the lead to maternal death, what has led to it, right? What has led to that cardiac arrest, and big number of them are all potentially treatable causes and potentially preventable causes. Now, because of the particular physiology and anatomy of the pregnant mother, that will influence a little bit how resuscitation is done. Okay, and also when to trigger resuscitation, when you start the resuscitation, and how it's done. And you keep in mind that the fetus is completely dependent on the well-being of the mother. So when you're resuscitating the mother, you're resuscitating the fetus. Okay? All right, so what's particular in pregnancy? So the uterine blood flow, of course, is determined by perfusion pressure. And if the maternal blood pressure goes down, the blood going to the uterus decreases. And of course, if blood going to the uterus decreases, it means that there's going to be less oxygen delivered through the placenta to the baby. Okay? The uterus, the pregnant uterus, receives up to 30% of the maternal cardiac output. Okay? And the bigger the uterus, so the more advanced in pregnancy the mother is, and definitely from 20 weeks onwards, the uterus compresses the maternal aorta and the maternal inferior vena cava. What does that mean? So this aorta cava compression means that with the mother, I mean, especially, if she's lying down on her back, but even when she's not, but particularly when she's lying down on her back, the pregnant uterus beyond 20 weeks starts pressing on the maternal aorta and the inferior vena cava, meaning that the cardiac output, right, the blood coming out from the maternal heart, part of it is sequestered, right, because of the pressure that the pregnant uterus applies on the aorta and the inferior vena cava, particularly when she's lying down. And in fact, that's why in this picture here, right, when you're doing resuscitation on the mother, either if you're going to leave the mother face up, I mean, back, the back level and completely face up, you need to displace the uterus, or else you tilt the mother, so that by tilting the mother, you're displacing the uterus. By displacing the uterus, it means that the uterus is no longer pressing on the aorta and on the inferior vena cava, and that will help the cardiac output, that is the pumping of the heart, will help the cardiac output to increase by 30%. Okay? Exactly. So the uterine displacement, by moving the uterus to the side, usually towards the left, that increases cardiac output by 25%, because the pregnant uterus is no longer directly pressing on the aorta and the inferior vena cava. All right, the other difference is that when we're implementing maternal resuscitation, there is this 4-minute rule. What does this mean? So basically, of course, if the mother is not breathing, there's apnea, there's going to be a rapid decline in arterial pH and her partial pressure of oxygen. Of course, the fetus, which is completely dependent on the oxygen from the mother, basically, the fetus has less than 2 minutes oxygen reserve of his own, right? So if he's not receiving any oxygen from the mother because the mother is not breathing and the heart is not beating, it has less than 2 minutes of oxygen reserve, which means that if you're doing CPR on a pregnant mother and you've been going on for 4 minutes and there hasn't been restoration of circulation, so the heart of the mother is not beating still, you need to go for dramatic action. And dramatic action is basically doing a cesarean to remove the baby, to deliver the baby, because in so doing, I mean, if the baby is to remain inside, still the baby is not getting any oxygen. And also, by delivering the baby, you are using that amount of aortocaval compression, and therefore you can continue with your CPR better, because there is the uterus now is not pressing more of the blood from the mother. All right, so like the usual resuscitation, the usual CPR, you start with your airway. You're going to open the airway to make sure that she's receiving oxygen, and at the same time, you have your circulation going by giving chest compression. And you're quick to move to defibrillation. So ideally, you have access to defibrillation in order to assess and shock if there is ventricular fibrillation or ventricular tachycardia. And you can shock up to 3 times. Of course, be in place as soon as possible. You confirm that the mother is receiving enough oxygen. You establish IV access, right? So as you call for help, which of course assume that you've called for help, right? and you're doing your chest compressions. In the meantime, someone is putting in the IV, someone is putting in the ECG monitor or the monitor of the defibrillator to get your rhythm, and getting hold of the drugs, and also looking for a possible diagnosis of what has led to this. For example, as I mentioned before, if there is, let's say, a uterine inversion, which of course needs to be corrected because otherwise the mother is never going to recuperate. Okay, so this is in summary how the normal CPR is applied to a pregnant mother. Okay, so of course you call for help because you need more hands on deck. Okay, usually most hospitals would have a CPR team on call. Okay, so when you call for help and you press the button and call the CPR team, you get the team on call coming in. And you start very often, as you're making sure that you've got your airway in place, you are quick to go for the circulation. Okay, so you start the compressions. To start the compressions, you need your your uterus to be displaced to the left. All right, so either you've got your assistant who is moving the uterus to the left, or else you get your assistant to act like a human wedge so that the mother can be tilted to the left, or you get a chair. I mean, you get something which helps to displace the uterus. Of course, if she has a fetal monitor, you remove it and you start your compressions. Okay, the compressions are usually 100 compressions per minute. You push hard and fast, of course, and ideally, when help comes, you change compressors. So first I do 1 to 2 minutes, and then the other colleague does the 1 to 2 minutes. All right, in the meantime, someone's taking care of the airway, and also for every 30 compressions, giving 2 breaths. Now, these sometimes change from time to time. Sometimes it's 15 to 1 or 30 to 2, but ultimately, you've established the compressions and trying to get that heart going, and then in the meantime, pumping in oxygen. Okay, then you're quick to go for the defibrillator if you're not getting a response. Okay, so you do that, and the same defibrillator will also keep an eye, it will keep an eye on the ECG. And if this has been going on for, by 4 minutes, ideally, you need to think of you need to go for delivery. And the idea of going for delivery is because anyway, the baby, if the mother is not breathing and the mother is not, pumping oxygenated blood to the baby is at risk. And also the reason you deliver the baby is in order to be able to remove the aortic valve compression, and then you can continue with your CPI the normal way without having the mother tilted. And also by this time, more help would hopefully be there, and you give your drugs. Usually the first drug you give is the epinephrine, this to the mother. So the left uterine displacement, so as I said, it can be done manually by standing on the patient's left side and gently pushing the uterus to the left, or else you can do a firm wedge, so whether it's a blanket or a rolled towel or a chair upside down, so you put it under the mother's right hip to create a tilt of a maximum of 30 degrees. Like that, the pressure on the inferior vena cava and the aorta is relieved, and therefore you improve the venous return and cardiac output. Okay, and if then you're going for cesarean delivery, what Morton cesarean delivery, the whole point is, not only to save the baby, but also to give a better chance for the mother to restore her circulation and her oxygenation. Okay, so this is to explain the tilt. So basically, normally with the mother face up, okay, she would be, the pregnant uterus beyond 20 weeks is pressing on the aorta and on the inferior vena cava. By tilting to the left, okay, either tilting the whole mother or by doing the left uterine displacement, you are relieving the aortocaval compression. Okay, so like that, the cardiac output improves, and therefore, even the chances of successful CPR improves. Okay, all right, and this is taken, I think, from a 2020 paper, okay, which is, I'm sure your own hospital will have its own team, and I'm sure you get your skills and drills being done on a routine basis, because of course, I mean, when a maternal cardiac arrest happens, everyone needs to know what to do. Okay, so it's one of the first things that someone who's new to delivery suite, they get to practice, and every 6 months or so we'll do these skill centers, and maternal CPR, it would be one of them. Okay, we also make sure that the defibrillators are working properly, they get checked, because, I mean, hopefully you never get to use them, or if you get to use them, you need to make sure that they are functioning properly. Okay. So, of course, as this is happening, you try to find out the etiology of why she arrested. As I mentioned before, it could be uterine rupture, in which case you need to rush to theater to deliver the baby. Anyway, it could be uterine inversion after delivering the baby. I mean, it could be many reasons. It could be unfortunate amniotic embolism, okay, which is, I mean, luckily not common, but when it happens, there is an increased chance of maternal mortality. All right, so the key differences from standard CPR is that you need to get your obstetric and even neonatal teams early, of course, because even the baby, once born, will most probably need resuscitation. In fact, the next topic is going to be neonatal resuscitation. You start with your compressions, and the hands are placed just slightly higher on the sternum to accommodate the elevated diaphragm because of the pregnant uterus. Okay, you do the manual left uterine displacement, or else put the patient on a wedge, depending on what's available, how many people you are in the room. The patient's airway, you defibrillate, and the dosing is basically, I mean, you start with epinephrine, okay? And you look for reversible causes, whether it's the PPH, whether it's the eclampsia, amniotic fluid embolism, okay? And remember, you've got your 4 minutes, because if nothing has happened, you need to get your baby out. So there needs to be delivery definitely by 5 minutes. So you're ready to do a cross section that within 1 minute the baby is out. And then you continue your resuscitation after delivery. I mean, you manage an hemorrhage very aggressively. And of course, coordinate with the neonatal team in view of the neonatal resuscitation. If unfortunately you have to move to this perimortem cesarean section, ideally you have your skilled personnel and equipment. You move to it if there has been no spontaneous maternal circulation for 4 minutes. And as I said, the idea is not only to save the baby, but even more so to save the mother by removing the aortocaval compression. I mean, ideally it's done if the baby is more than, 23, 24 weeks, in order to, I mean, first of all, because if the baby is smaller than that, probably there is not so much aortocaval compression in the first place. And also to try to make sure that you save both baby and mom. Normally the incision, both in the skin and on the uterus, you do it vertical and it's midline. And as soon as the baby is delivered, like within that 1 minute cross section, the infant, you need to dry and warm the infant. You peg the uterus, okay, and you remove the lateral teeth and continue your CPR. And of course, then the repair happens once the patient is stable. I think in total, I wasn't directly involved in the perimortem cesarean section, but when I was working in London, there were 2 cases of perimortem cesarean section. One of them, unfortunately, the mother was found, well, probably she had been dead at home for a while, but by the time the medical team went on the spot, I mean, when they saw that she was pregnant, I mean, they did the perimortem cesarean, but it was too late, so both mom and baby had passed away. And there was another case who actually had a good outcome. I mean, and both mom and baby, the baby, of course, after quite some time in NPICU, but both then had a good outcome. So that is maternal resuscitation. Then the next point is neonatal resus. So I don't know, if, Abigail, if you want me to carry on with neonatal resus and then we have questions after that, should we do that? Because they kind of tie in together.
Oh, okay, Prof. Okay.
Yeah, there's not a lot of slides left, don't worry. So neonatal resus, I mean, this will be something that, again, I mean, we can practice on the doll. I'm sure you're probably very well experienced in doing this, but you know, practice is never a bad thing. So neonatal resus, these guidelines for neonatal resus have changed very recently. So what I'm going to present you here is the 2025 guidelines. They haven't changed drastically, but they've just been recently updated last year. All right, so why would we need to resuscitate the neonates? So when a baby is born and with a low UPGAR score, right, and you need to move towards resuscitating the baby, of course, the causes leading to that baby being unwell, there could be antepartum causes or intrapartum causes. And but whichever reason, so whether it was antepartum factors or intrapartum factors, you're going to resuscitate in the same way irrespectively. And then, of course, after that, then you find out the underlying cause, okay? And finding the underlying cause is important because the longer that the baby has been at reduced oxygen, of course, especially if it starts at antepartum, the prognosis is going to be, you know, a bit worse, likely to be worse than if it was something temporary, let's say, during the delivery of hypoxia. Difference to the outcome, both in the short term and in the long term. But antepartum factors, they could be intrauterine growth restriction, prematurity, multiple pregnancies, a serious congenital anomaly, oligo or polyhydramnios. Oligohydramnios, of course, because if there is less amniotic fluid, there is less room for the fetal lungs to develop. So while the fetus would be okay while still in utero, once born and then needing to take the first breath, if the lungs are hypoplastic, that's going to have implications and needing neonatal resuscitation. There could be maternal factors antenatally, which also lead to the baby needing resuscitation, and these include infection, gestational diabetes, pregnancy-induced hypertension and preeclampsia, high BMI, short stature, because short stature is linked with prolonged labor, difficult labor, or assisted delivery. And of course, if the mother starts contracting and the pregnancy is still premature, so let's say less than 36 weeks, and she delivers preterm, and maybe it's unexpected, and the water is ruptured, she starts contracting, and there wouldn't have been time to receive the antenatal steroids. Of course, there is increased risk of fetal and respiratory disease, okay, neonatal respiratory disease. And then there are intrapartum factors which lead to the baby needing resuscitation. We already mentioned forceps and vacuum delivery, because potentially of trauma, but even because of the reasons for which you ended up doing the forceps or vacuum delivery. If there is evidence of fetal compromise, meconium, stained amniotic fluid, breech delivery, especially if it being a difficult breech delivery where the head took some time before it got delivered, if there has been intrapartum or antepartum hemorrhage, early cesarean section, even an emergency cesarean section at term. I mean, there is what's called the transient apnea of the newborn, and in fact, after every section, emergency or elective, the baby gets checked immediately by the pediatrician on call. Even general anesthesia, of course, the baby might born with transient apnea, and out of hospital birth, especially if it's been complicated birth, can also lead to problems with the baby needing help. All right, so again, this is taken from the 2025 guidelines. So key messages involving neonatal life support. So they actually recommend delayed cord clamping in order to leave more room for the oxygenated blood to reach the baby till the baby takes the first breath. The stimulation, so drying the baby, wrapping, changing the towel to another dry towel, like that, you're stimulating the baby and keeping the baby warm. Okay, so as I said with towel, so you have two towels. With the first towel, you dry the baby and then remove that first towel and take the second towel. Ideally, these towels are warm to start off with, and you keep the baby warm. Okay, so that helps with stimulation and usually stimulates the baby to take his first breath by crying. Okay. Then you assess the breathing and heart rate. Okay, so you're doing your UpGuard, and if there is problem with breathing, you open the airway. So by making the baby's head flexed, like breathing the morning air. Okay, so you open the airway, and if need be, you inflate the lungs by putting a mask, an appropriately sized mask. So if it is a premature baby, you put a small mask. If it's a normal sized baby, you put a bigger mask. If, as you're assessing, there is a problem with the heartbeat, so there's no heartbeat, you start your chest compressions. Very often, luckily, you don't need to go that far, because by adjusting the airway and by the stimulation and adjusting the airway, usually that's enough. Now, babies are actually much more resilient than we think. But if you need to go for chest compressions, you have to go for chest compressions. And if you need to give medications, usually the umbilical vein is the preferred vascular access. If you're dealing with a very premature baby, less than 32 weeks, it's a bit more complicated. You need to use your CPAP. You might put the baby in a plastic bed. You need to use, very importantly, low inflation pressures, okay, because the lungs of the baby are still premature, and you might need to give higher oxygen, okay, if you're dealing with a premature baby. Of course, if it's an unexpected out-of-hospital approach, you need to be even more careful because of hypoxemia and hypothermia, and communication with the parents is key. Remember, this is supposed to be the moment they've been expecting after, whole 9 months. And things might have been proceeding well during delivery, and then suddenly the baby is taken away and don't know what's happening. So communication before, surrounding, and even after birth is very key because, I mean, it can lead to serious perinatal mental health issues with the parents. I mean, if we fail at communicating, I mean, it's true, it would be it's a situation of panic, but communication is key. I mean, we now know that perinatal mental health is important, not only for the mother and the family, but even for the child, and ultimately the child, I mean, when the child starts her own family as well. All right, so I know this is a busy slide, but this is actually, I think it's the Lancet paper, where these latest guidelines, the 2025 guidelines for neonatal resus, are listed. Okay, so basically, as usual, you ask for help, you start the clock. So the time is very important because you need to assess the situation very often, and you need to time your the procedures which are going to take place. So at birth, you start the clock. It's recommended to do the delayed cord clamping, the gentle stimulation by drying the baby and wrapping them in a new and warm towel. Okay. And if need be, even the baby wears a hat. And if need be, the baby stays in the resuscitator, so the baby is warm. So you assess the breathing and the heart rate. If there is inadequate breathing, you have to open the airway, by lifting the chin, and like the nose of the baby is like breathing the morning air. Okay. If there is apnea or gasping, you give the 5 inflation breaths. So these 5 inflation breaths, basically you need to make sure you choose the right size mask, right? So if it's a premature baby or a normal size baby, the mask, it needs to cover the nose and the mouth, and it needs to be tightly sealed, of course, not going over the baby's eyes, right? And there has to be a seal. So you apply these 5 inflation breaths. I mean, what you're doing when you're doing these inflation breaths, you are actually helping to push any fluid. Remember, the baby would have just been delivered, so the baby, up till a few seconds ago, was still surrounded by the amniotic fluid from the mother. So by giving the inflation breaths, you are pushing the amniotic fluid within the alveoli. I mean, that remaining fluid in the alveoli, you're pushing it further in, so it becomes tissue fluid. And therefore, the lungs, the alveoli won't be underwater anymore. They would be able to start respiring, right? The oxygen can be transported from the baby's lungs to the baby's blood. So you give your 5 inflation breaths and you reassess. If there has been an increase in heart rate, right? Good, right? You can continue watching the baby. If there has been no increase in heart rate, you want to check whether there is chest movement. Because if the chest hasn't moved, you need to make sure that you can't, it's useless giving chest compressions if no air is reaching the baby. So if you with your 5 inflation breaths, the chest is still not moving, you need to repeat your 5 inflation breaths. You might need to readjust the airway, okay, or the head position, or doing the jaw thrust. You might need to use a bit of a higher inflation pressure, but you have to repeat them. You need to get that fluid away from the alveoli. Otherwise, whatever you do, it's not going to work. So you assess, and again, you check if there has been if there is and there's chest movement. Hopefully, you would have got your chest movement after 2 tries. And then, if there is no heart rate, you need to basically, of course, if there is no chest movement, you need to keep on doing your inflation breath. But if the heart rate is there, and you've given your 5 inflation breaths, and the chest has been moving with these with these inflation breaths. But if the heart remains low, after having made sure that your inflation have worked, okay, so air has managed to enter the lungs, so you start your chest compressions. And the latest recommendations are that you give 3 compressions to 1 ventilation. So a ventilation breath is a bit different from the inflation breath, because the inflation breath, you use a bit of more high pressure, because remember, the idea of the inflation breath is that you push that fluid from the alveoli so that the alveoli can allow the fusion of oxygen. With the ventilation breath, they are slower and more gentle. Okay, you of course have high oxygen, in this case, right? It's 100%. While with the inflation, it was 21%. And here you have high oxygen levels. Okay, and you continue with the 3:1, reassessing every 30 seconds. If after the first 30 seconds the heart rate is low, okay, you need to move on to having vascular access and giving the medicine. It's usually adrenaline, IV, potentially even glucose. Okay? And of course, if there is still no response, you have to think of a potential congenital anomaly or a pneumothorax, or for example, a diaphragmatic hernia, where the lungs are being compressed by the bowels, or hypovolemia, or equipment failure. I mean, so those would be, these are the guidelines, actually, the latest guidelines on neonatal resus. Okay, so notice the emphasis which is placed on the inflation breaths, because, if the lungs are still underwater, you can't proceed. So the inflation breaths and the chest movement with the inflation breaths, I mean, at least with the 5 inflation breaths, if at least you get chest movements with at least 3 of them, that means that air is managing to get into the lungs. Okay. So these slides, I mean, you're going to have, and this is very important. I mean, in our case, I mean, we've got a laminated version of this with a resuscitator in each room in the delivery suite. Okay, because like in the case of maternal resuscitation, unfortunately, neonatal resuscitation, I mean, sometimes you can predict that the baby would need help, like, for example, after doing a cesarean section for respiratory distress, okay, and for fetal distress. But sometimes, I mean, you can have, everything proceeding normally, and then this baby is born limp and with a low UPGAR score. All right, and again, this is taken from the same paper on the 2025 guidelines. So you assess, all right, and if the baby responds with gentle tactile stimulation, then, I mean, you just stop there. And if the breathing is regular, the heart rate is more than 100, you have dried the baby and wrapped him in a nice warm towel. I mean, you stop there and you're happy, and the baby remains with the mother. If the breathing is inadequate and the heart rate is low, you first do the stimulation, but then you think about the inflation, well, not think, you proceed to the inflation and possibly ventilation. But if the heart is less than 60, not only do you do the inflation and the ventilation, but you do the compressions, the 3:1 and compressions. 3 compressions is to 1 ventilation, and you continue monitoring. And that has led us, yes, we actually, okay, just half an hour behind time, but we started half an hour late, but we've managed to finish that, still within the 2 hours. Okay. I'm sure that you're very familiar. You're probably even better than me, Teresa's. I mean, in my case, I myself, I mean, apart from during courses and on dolls, I mean, normally I don't do neonatal resus myself. I mean, it's usually the team, the midwives would start it, and then the pediatrician, and if the pediatrician is already present during delivery, the pediatrician then will take over the neonatal resuscitation. But of course, even as obstetricians, we need to be familiar because we might be the only ones in the room during the delivery. And if that happens, and you need to resuscitate, at least you know where to start.
Wow. Thank you so much, Prof. This, I would say, has been very, very educative from the first session to the last session. We really, really appreciate your time because sometimes you'll be at work and you'll be rushing in, so you'll be able to come and teach us. We really appreciate your efforts. Thank you so, so much. We are very humbled. And thank you to the colleagues that also joined. We really appreciate your time. I'm sure we've all received something into our pockets. Thank you so much. Thank you to the IT team. And thank you to the team that also organized this whole session. And I think our next session, we'll be seeing Prof in person
Yes, I'm really
in
looking forward
Ghana
to
very soon. Yes, we'll be seeing Prof in person. And then that will be for our practical session, which will be commencing on the 18th of June
Yes.
to the 22nd of June. And then it will be strictly practicals. So let's prepare ourselves to also um, get our minds on for the practical session for everything that we've studied so far. So thank you so much, Prof. Thank you.
Very
Really
good.
appreciate your time. Yes, please.
I,
And
I
do
really,
you want to say something?
I really enjoyed it, really.
Right.
They have passed really quickly, these 8 sessions.
Yeah.
And yes, and I'm really, really looking forward to see you, really. And I'm sure I've already learned a lot from you because I mean,
Mhm.
when you shared your experiences, and I'm sure I'm going to learn even more when we meet
Right.
there. This
Right.
is, the beautiful thing about healthcare, that we learn
Yeah.
from there in order to make it better for
Mhm.
our.
Mhm. Right. Thank you. Thank you so much. So we'll end the session here and then we'll prep ourselves in seeing you in person on the 18th of June. And when you're coming, have a very safe flight.
Thank you. Thank you.
Thank you so much. Thank you. All
Thank
right,
you.
colleagues. Have a good evening. We'll end the session now. All right. Bye, Prof.
Bye bye. Bye bye. Thank you, Abigail. Thank you, everybody. Thank you.